So without wasting any time, I would ask my co-chair, Dr. Professor H.K. Chopra and Devanu, to have some comments, and then I would request Dr. Rabin Chakraborty, who is also a very learned person and very old friend of mine. So Rabin, you can proceed after the short comments.
Thank you very much, Deban Kale. I think it's a very important, very nice talk. But I just like to give one comment. A lot of work has been done recently on LA strain evaluation. And when we find the patients with reduction in the LA strain, the paroxysmal atrial fibrillation become recurrent, resistant, permanent, and they don't need any rhythm control because rhythm control is not successful. Most of the patient radio frequency ablation fails. The radio frequency ablation fail rate is higher in the people having reduction in the LA strain, number one. Number two, we do these days LA stiffness index. Higher is the stiffness of the left atrium, more resistant is the atrial fibrillation, and more is the failure rate of radio frequency ablation. So I think whenever we do a radio frequency ablation, we must evaluate LA stiffness. And just one more point, recently there's a lot of data coming up in the European Heart Journal that the cause of high LA remodeling or LA strain rate is because of LA fibrosis. This is related to high levels of aldosterone. If these patients are given higher doses of aldosterone, maybe something better. As already pointed out by Dibankar very rightly, that higher is the age group, higher is the atrial fibrillation, higher is the resistance in the treatment. I think these are very important challenging issues which we need to address over a period of time. Thank you. I think it was very nice and brilliant talk.
Thank you, sir.
I'd just like to add that this topic, rate control versus rhythm control, this debate is going on for the last 30 years. And I believe that in majority of the patients, it doesn't matter which procedure we apply. Because had any rhythm strategy been better, the debate would have ended by now. So in majority of the patients, it doesn't matter whether you go for rate control, rhythm control. In a minority of patients, actually rate control is good. And again, in a minority of patients, rhythm control is good. We need to select out these patients which will go for rate control or rhythm control. But in majority of patients, it doesn't matter which one you do. Yes, Professor Rabin Chakraborty, please. You can start your discussion.
Yeah, good evening, everybody. Thank you very much. First of all, I must thank Professor Shantanu Guha for such a wonderful meeting. And now we can believe that even when the world is quiet and being locked, but we can continue our scientific activity. So we are going to talk on the rhythm control on atrial fibrillation. I just requested Jignesh to upload my slides. Jignesh, can you upload my slides? Because I'm trying from here. Jignesh? Right. So I'm going to talk on rhythm control should be tried in majority of the cases. And to talk on that, we'll start with the case. And this case is, can you move to the next slide? He's a 65-year-old gentleman with a recent episode of palpitation, weakness, and lightheadedness. He describes his symptom, which has been occurring often for last 3 times every day for about a week. And when it happens, he feels really awful. And the next one shows, the next slide, that he is a known patient of hypertension, diabetes, and also has a history of sleep apnea syndrome, and is on lisinopril, metoprolol, and insulin for diabetes. And next one. His blood pressure is 145/90, heart rate is 85. He is a little bit of overweight for his height, and on auscultation, the normal heart sounds, no with variable intensity, no murmur, and pulse is irregular. Otherwise, all other findings are unremarkable. Next one. And next slide. This is the ECG, which you can see clearly. This is an atrial fibrillation. and heart rate is probably around 100, and this is the kind of history. So how we are going to treat this patient is a new onset of atrial fibrillation with a background of hypertension, and he is awful when he is on when he gets such symptoms. Therefore, the main line of treatment was, next slide, to control his antihypertensive drugs. In addition to that, beta blocker to assess left ventricular function, and also to consider antiarrhythmic drug, maybe precaride or propafenone, and of course anticoagulant. Maybe you can consider NOAC, and you also have to do an echocardiogram to assess left ventricular function. Next one. Now, why we should talk in any cardiology meeting today on atrial fibrillation? Why it is important? Because the atrial fibrillation is an arrhythmia which we know for years together, probably from 1960s or even before that. But today we know, even for, I would say, for the last 10, 15 years, we are progressively becoming aware that atrial fibrillation, if it continues, it may cause catastrophe in life. For example, it may cause a very bad sort of cerebrovascular stroke, when the life is completely debilitating, and heart failure. Heart failure both ways. Atrial fibrillation can cause heart failure, or atrial fibrillation in presence of heart failure can make the cardiovascular the situation condition is very, very bad. Next one. And this is a data which has been published recently last year in American Heart Journal, shows that with a rhythm control, there is a survival probability is more if you can treat them well. We have to also recognize that in AFFIRM trial, which is a very old trial, a lot of medication, the understanding of atrial fibrillation was not as clear as it is today. The algorithm of management of atrial fibrillation has remarkably changed. So therefore, it is probably very important to revisit the management of atrial fibrillation. Next one. So I will start with this kind of a slide, which is very interesting. This is a data collected from a registry called Get With the Guideline Heart Failure Registry. GWTG heart failure, the data being collected from 2008 till 2014, and which describe the treatment for rate versus rhythm control and subsequent outcome in patients with preserved ejection fraction and atrial fibrillation. Rhythm control was defined as use of antiarrhythmic medication, cardioversion, or even ablation. Rate control was defined as use of combination of beta blocker, calcium channel blocker, digoxin, without evidence of rhythm control. And if you, when they analyze the whole data, which was done recently, and there is a higher all-cause death at 1 year in the rate control compared with the rhythm control. The lower 1 year all-cause death in the rhythm control continued to remain. They remain low even for a longer period of time. And this is very interesting data, interesting observation, that rhythm control has a definite role in atrial fibrillation, which we are going to talk more and more as we move forward. Next one. And atrial fibrillation, the reason is the atrial fibrillation, unlike many arrhythmias, is a very complex arrhythmia. Why it is complex? Because the existing limitation of the rhythm control strategy, as Dipankar has said very nicely, there's a lot of limitations because of the methodology and the result of the complexity of arrhythmia. Atrial fibrillation is a multifactorial arrhythmic syndrome with a common electrical phenotype. It is a marker, a witness of the disease, even or its severity, and even itself is a risk factor for cardiovascular disease with causal implication. So rhythm control as a part of the management of atrial fibrillation considered a very important factor, and it implies for the prevention of cardiovascular disease and its progression. And if you move further, the next slide shows us the key elements for atrial fibrillation initiation and perpetuation is represented by substrate remodeling under the influence of traditional risk factors, under the influence of the genetic susceptibility. The remodeling process involves electrical substrate, the ion channel, the functional and morphological substrate like fibrosis, and intracellular calcium handling, which is responsible for the premature atrial ectopic activity. The substrate remodeling and triggered activity essential for atrial fibrillation initiation and perpetuation and leading to a vulnerable target for the efficient rhythm control. Dipankar said atrial fibrillation begets atrial fibrillation, which he knew from 1990 or even late 80s onward. This is a phrase which is pointing towards fibrotic remodeling. However, the remodeling process is much more complex. So therefore, the success of strategies at maintaining the sinus rhythm is highly dependent on timely intervention degree of substrate modification. Therefore, when you manage atrial fibrillation, be it by rate control or by the rhythm control, never ever forget, and we must not forget, that there is a substrate behind it. It could be ischemic heart disease, it could be hypertensive heart disease, it could be primary muscle disease of the heart, it could be diabetes mellitus, so many other factors are there. So it is therefore essential that when you treat the rhythm, either by rate or by for rhythm, never ever forget that these substrate also has been taken care of. When you talk about FM data or even the data prior to 2010, I'm sure that many of these patients were not being treated concurrently with the medication, which is essential for the substrate like morphological substrate, electrical substrate, genetic substrate, and I'm sure that even today's talk is the last talk on atrial fibrillation. Even next year and year, we're going to talk more and more, because a lot of work to be done even on the ion challenge, the electrical substrate, and many other things. Therefore, it is important to recognize the substrate first before talking about either the rate control or the rhythm control. If we move further, look at the next one. Next slide. This is a very interesting slide. It shows that atrial fibrillation as a marker or a factor of risk. Like you have multiple risk factors, then you got markers, multifactorial pathway, then you got substrate remodeling, which is modulation, and then it goes to a common pathway leading into atrial fibrillation. So when you hit atrial fibrillation, either to control the rate or to control the rhythm, you are not actually thinking that the ladder much ahead of it, because these are the things which has to be understood. And this is a nice paper being published last year. If we move further, next one, it says the guideline statement may generate puzzling reaction. First, despite scientific evidence showing no difference in outcome between rate control and rhythm control strategies, many practitioners still today believe that maintaining sinus rhythm improve outcomes. Second, there is a false impression that sinus rhythm and atrial fibrillation equivalent in terms of function and outcome that may be reduced. The sub-analysis from atrial fibrillation follow-up study like AFFIRM study clearly demonstrated that preservation of sinus rhythm has a better survival risk reduction is approximately 46%. However, antiarrhythmic use for sinus rhythm preservation induced an almost equivalent increase in mortality because, as Dipankar said, there are drugs which itself has got pro-arrhythmic effect, which I'm going to come back a little later. Next one. So the recent trial is interesting. The camera MRI trial is a catheter ablation versus medical rate control atrial fibrillation dysfunction study emphasized the importance of sinus rhythm for optimum in atrial fibrillation patient with systolic dysfunction of uncertain etiology. In this study, the left ventricular ejection fraction improved significantly in patients who underwent catheter ablation compared to the patients on traditional medical treatment. This important study has shown that improvement was obtained in patients with minimal ventricular fibrotic remodeling. So when you did an MRI and with a late gadolinium enhancement study, if you have documented there is a less fibrosis, the substrate is not that bad, then probably the rhythm arm would be a better option rather than the rate arm. If we move further, next one, then because we need to understand the pathophysiology of arrhythmia, now let us talk about the heart failure. This is a great slide of my friend Sham Ashirbadan from Mayo Clinic. And Sham has showed that this atrial fibrillation is basically a kind of there could be a pulmonary vein or ectopic trigger that comes because there's a substrate like hypertensive heart disease or ischemic heart disease. And then there are modulating factors like autonomic nervous system, electrolyte, there could be fixed scar, or even this inflammation, silent inflammation of myocarditis, which has been clearly documented by cardiac MRI. And that creates an ectopic. And that ectopic quickly degenerates into atrial fibrillation through multiple wavelet theory. So this pathophysiology of arrhythmia in congestive heart failure or even a mechanism of atrial fibrillation is very important for all of us to understand. Next one. And the next slide shows, so there's a progression of atrial fibrillation as a function of atrial remodeling and strategies for prevention, which means there's upstream therapy and risk factor management. Then there's a paroxysmal atrial fibrillation. This is the presentation at which we see the patient, but we don't understand the background behind it. So you try to intervene either by rate control or by rhythm control. Maybe rhythm control at this point of at this point. If you ignore it, it goes on to persistent, the long persistent, and eventually become permanent. So this is a kind of the car which goes up, and there's a huge volume of atrial fibrillation comes here. So if you understand this and address at this point and this point, even by definition, permanent means that you have actually made an attempt to bring it back to sinus rhythm and you fail. That is the definition of permanent atrial fibrillation. So the recommendation by Melvin Scheinmer from San Francisco. Melvin Scheinmer clearly said that whatever may be, you make an attempt to see that whether it comes back to sinus rhythm or not. If it doesn't, then of course you have another option open, which is rate control. If we move to the next slide, and that shows that the concept of atrial cardiomyopathy we need to understand today. So if you leave it at atrial fibrillation and without even considering rhythm arm at all, without even considering that you should make an attempt to bring it back to sinus rhythm, then actually you are keeping a gate open for the patient to proceed for atrial cardiomyopathy, which has its own problem, which has its own complication. Next slide. So there's one contemporary study has raised enthusiasm and hope, but also there's some skepticism. The catheter ablation for atrial fibrillation with heart failure CASTLE-AF study included 394 patients with ejection fraction is less than 35%. 70% of them receiving rate control and anti-arrhythmic drug being discouraged. 30% received the other option. There's a crossover, and the A burden was significantly decreased in the ablation group. The point is, there is no point of arguing whether ablation is successful or failure, whether rhythm or control is failure or successful. What is important, if you can bring it back to sinus rhythm, even for a given period of time, you're actually the volume of atrial fibrillation. So the number of atrial arrhythmias, the volume determines the long-term complication, long-term outcome, as well as the cardiomyopathy coming from the heart rhythm disorder. Next one. However, it should be emphasized that interpretation of drug safety is important. As Dipankar said, that these drugs has got definitely proarrhythmic activity. We need to understand the new drugs which are coming up. The Athena trial included high-risk patients, and they found that probably dronabinol they found to be quite helpful, and it also found to prevent the death of the patient, and which was not probably true with the standard therapy as we recommend today. Next one. This is a case, you can see clearly atrial fibrillation, maybe the hypertensive heart disease or some kind of hypertrophied heart leading into this. But maybe the other one, next one, this one has showed that there is complete left bundle block as well as there's a left bundle block with atrial fibrillation. This patient has got significant cardiovascular disease. The chances of bringing this back to a sinus rhythm would be rather low, very, very low. So you have to work much before this thing has happened to the patient. For example, maybe this patient is ischemic heart disease or cardiomyopathy or something like that. Next one. And the next one you can see this, that was another one. You can see again, left bundle block. I think the previous one was right bundle block. Sorry. This was the left bundle block. Again, there's a cardiovascular disease. They already the substrate is gone. There's severe scar, severe fibrosis. Next one. So I'm going to conclude my talk here. So today in 2020, we should also understand that rhythm control has to be tried. One has to understand we have been trying so far with sotalol, amiodarone, flecainide, propafenone. But we also need to have upstream therapy like ACE inhibitor, angiotensin 2 receptor blocker, statin, and these drugs are important. In addition to that, those drugs, those trials of Rapam and others, people use diltiazem, people use other drugs. So those drugs we don't use today. The things have changed a lot. So again, the new drugs are probably coming back. We should also have an emphasis towards flecainide, propafenone, and also to identify that in which subgroup of patients these are useful drugs, these are good drugs, remarkable drug. If you have good ejection fraction, no background of ischemic heart disease, is a great drug and it maintains sinus rhythm for a longer period of time, and we have data to support by ambulatory monitoring. Next one. So people talked about ablation, focal atrial fibrillation. Next one. Even we can do next one. Focus, which you can remove. Next one. Next. Next. And you can also do a three-dimensional mapping to get a better idea and to reduce the volume of the substrate as much as possible. Next one. So both interventional and pharmacological therapy need to consider the acquired progress in understanding atrial fibrillation mechanism. Today, new target for antiarrhythmic drug will be represented by specific atrial current remodeling drugs like ultra-rapid potassium current, the acetylcholine-dependent potassium current, and the TSK family potassium current. These drugs are coming up. Another important target for modern AAD is represented by other drug called ryanodine receptors, calmodulin-dependent protein kinase. So these drugs are coming up because they will go to address the substrate more precisely. They have to eliminate the complications like atrial fibrillation and to maintain the sinus rhythm on a long-term basis. Therefore, maintain the quality of life, reduce the complication, reduce the mortality, reduce the hospitalization, and reduce the complication of atrial fibrillation. Next one. So before I talk, so to summarize, I think we should make an attempt to bring back to sinus rhythm. At least one attempt should be made to convert to sinus rhythm. If preserved ejection fraction more than 50%, try with flecainide or propafenone, or even with IV ibutylite in coronary care. I don't know how many people have used IV ibutylite. I use IV ibutylite. I've got a very good response. If LV dysfunction, try amiodarone IV to start with and oral. Even you can actually consider DC cardioversion after transesophageal echocardiogram and anticoagulation. Next one. So pharmacological drugs like amiodarone, ibutylite, flecainide, propafenone, disopyramide, non-pharmacological DC cardioversion, radiofrequency ablation, and conventional radiofrequency ablation, or by 3D mapping system ablation. Next one. So to summarize, these are the patients where maybe you can control, think of a rate control, persistent AFib, recurrent AFib, less symptomatic, well tolerated, elderly individual, large left atrium, associated chronic obstructive airway disease, CKD, and other medical diseases, previous rhythm treatment failed, and patient preference. And certainly you should consider rhythm control with paroxysmal atrial fibrillation, first episode of atrial fibrillation, more symptomatic during atrial fibrillation, younger group of patients, no associated other medical disease, history of heart failure, no previous rhythm treatment, never even attempted. You should try to have an attempt, and always consider patient preference. You should talk to the patient, given both the options, and then make a decision how to proceed. Decision should be based on the current knowledge and explaining to the patient about the advantage and disadvantage, pros and cons of both the things. Thank you very much. Next one.
Thank you, Dr. Rabin Chakraborty. Excellent talk. I was listening to all your words. Very balanced talk. Both the speakers have done extremely well. And I do admit that we should attempt what Rabin just now told, to convert the patient, if possible, to sinus rhythm. And as he has indicated, that the new patients, the paroxysmal atrial fibrillation patients, the patients which he showed that who are non-CKD patients, non-COPD patients, these patients groups can come back to sinus rhythm, especially the LSI is less than 5. Or Dr. Chopra would like to mention that the stiffness index you would like to see, or the left atrial volume. And there are so many strains figures and other things the echocardiographers can tell us. And there are so many, LA volume is very important. And if it is suitable, we should at least try once or twice to get the patient back to the sinus rhythm, because there is no doubt that with little drugs like beta blockers, if we can get the patient back to the sinus rhythm, it's the best. But of course, if it is not possible, like persistent atrial fibrillation, permanent atrial fibrillation, we have to continue with the rate control. And both Castle AF study and the Cabana study, which we're thinking will be positive trials, turned out to be neutral or negative trials, because the intervention group didn't show any mortality benefit in comparison to the pharmacological treated group. So, but still we should try for it, because the main problem with the AFib ablation is that after 1 to 3 years, they come back again to atrial fibrillation. After initial conversion, they come back. So I would refer to Dr. H.K. Chopra for your valuable comments. And I should not forget to thank Dr. Shantanu Go. Professor Shantanu is a very good friend of mine for organizing such a beautiful, virtual conference. And he is showing how even in this lockdown phase, we can enjoy science at its utmost. Thank you, Shantanu, for your
Thank
great
you.
endeavor.
Thank you, Dr. Devan Kali. Let me congratulate and a brilliant presentation by Rabin Chakraborty. I think his message was very clear that it is the substrate modulation, and he also mentioned it is a substrate remodeling to be reversed by whatever best method is possible. And the last slide was so clear and so vivid that where we should have favor for rate reduction and where we should have a indication in favoring rhythm control. I think, as already mentioned by Dr. Diman Kali also, that we must see which are the associated comorbidities like COPD or CKD and patients more than 65 or less than 65. I think timely selection of patient is the need of the hour, very nicely expressed by Rabin Chakraborty. And he also mentioned we must focus on aldosterone levels. I think it is very clear. The way he's shown the pathways, very, very clear. I think this was a very nice message, how we can select our patient for a successful rhythm control without taking those patients who are already at high risk and may not respond to the rhythm control. Thank you very much. It was a really brilliant talk.
Thank you, Dr. Chopra. Devanu, you sum up the session and conclude.
Mute, unmute, Devanu, unmute.
I think both these speakers have made an excellent presentation, and they both agree actually on where to go for rate control and where to go for rhythm control. Both these speakers have made it absolutely clear that the rate control or rhythm control should be individualized. It is not the same for every patient. And what also I liked very much is that we should always try to prevent development of atrial fibrillation in patients with proper treatment of hypertension and other risk factors. Thank you both the speakers, and I thank Dr. Shantanu also for organizing this meeting and calling me.
Thank you, Devanu. Thank you very much. Thank you all the speakers and the chairpersons.